So welcome to lecture number 21. Last time we were talking about endocrine function, focusing on the thyroid gland. And I'd like to recap just a little bit of that, and then we're going to approach it from a diagnostic standpoint, put a little clinical bent to it. So if you refer back to plate 119, which is on thyroid function, to re-emphasize, thyroid gland has a multitude of functions. It produces the thyroid hormones, thyroxine, T4, and triiodothyronine, T3. So T3 and T4 are the thyroid hormones. They have as their target tissues a multitude of different tissues, including muscle cells, skeletal muscle, cardiac muscle, brain tissue. That all of these tissues require thyroid hormone for that kind of function. The release of T3 and T4 is under the control of thyroid stimulating hormone, TSH, which is released from the anterior pituitary. That in turn is under the control of thyrotropic hormone releasing hormone. So TSH release is stimulated by TRH. TRH is released from the hypothalamus. So there's the hypothalamic hormone, an anterior pituitary hormone, and then final production of the thyroid hormones. The secretion of all of these compounds is under negative feedback, meaning in a normally controlled animal, secretion of T3 and T4 is sensed by both the anterior pituitary and the hypothalamus to reduce production of TRH and TSH. So you'll see the T3, T4 rise. As they rise, they tend to shut themselves off and then decrease. So what happens when the system gets a little out of kilter? And actually down below they have some examples. And so let's review those again. Hypothyroidism is defined by decreases in T3 and T4. So that's what makes an animal hypothyroid. If it happens in youngsters, because of their requirements for T3 and T4 for the proper development of neural tissue, these individuals are not only underdeveloped skeletally, but they are underdeveloped in neural capacity, so cretin or cretinism. In adults, hypothyroidism is characterized in some cases by this mixed eczema, having to do with lipid deposition. The face kind of swells with lipid. Exercise intolerance, very sluggish, low metabolic rates. These individuals tend to become obese. All right? Same thing in animals. Hypothyroid horses, hypothyroid dogs, decreased physical capacity. Hyperthyroidism, in contrast, is elevated T3 and T4. Elevated metabolic rates. You might classify these individuals as hyperactive. They tend to be very, very thin. Why? Because they are metabolizing at very high rates all of their substrates, characterized by very skinny, gaunt individuals. So if we're looking in our animal world for a great example, take the cat. Cats tend to show a proclivity towards hyperthyroidism. Presenting, thin cat. Is it eating? Yes, eats all the time. All the time, constantly eating, very, very thin. You then palpate the neck, and normally in cats, the thyroid gland sits in the thoracic inlet, meaning that it's not normally palpable. In these hyperthyroid cats, they become enlarged, and to the point where they actually come out and are palpable right there at the thoracic inlet. So if you can feel a cat's thyroid, it's hyperthyroid. Now, we go ahead and we take a blood sample on this cat. Shows elevated levels of T3 and T4. So let's go ahead and create a an image here. So the cat's clinical signs: skinny, hyperactive, active, very active animal, eating. This should be skinny, eating all the time. We take a blood sample and we find that in fact it is a hyperthyroid cat, elevated levels of T3 and T4. What's the cause? What are the causes? This is an older cat, elevated levels T3, T4. How about a tumor? The characteristic of a tumor, or let's give it another name, we'll call it a neoplasia. Neoplasia means new growth of cells. So in fact, these tissues are hyperplastic. The thyroid consists of more cells, and the cells are increased in size. So they are not only hyperplastic, means increase in numbers. Hypertrophy means increase in size. We talked about that in skeletal muscle. We said when you exercise, your muscles hypertrophy, they don't become hyperplastic. Well, in a neoplasia or tumor, they become both. Normal control of cell growth is removed. These cells aren't under normal control, that is, not under normal feedback control. And they become kind of like hyperactive cells. So whatever their cellular function is, they do more of it. Well, if it's a thyroid cell, they produce more T3 and T4, and they're not sensitive to negative feedback. So let's look at that on our hypothalamus, anterior pituitary, and thyroid. Now the thyroid is producing T3 and T4. Under normal circumstances, these go back in a negative fashion and suppress the release of thyrotropic releasing hormone and thyroid stimulating hormone. If the tumor is in the thyroid gland, all right, this cat is very large, you're suspecting that. If you take and you run, and we've already run the blood sample, we know that it's elevated T3, T4. What should the levels of TSH and thyrotropic releasing hormones be? Good test question. Because these tissues are normal, they are sensitive to negative feedback. You have elevated levels of T3 and T4, so if you run a blood sample on that cat that has elevated T3 and T4, if the tumor is in the thyroid, TSH, TRH should be lower, depressed. What if the animal comes back elevated T3, T4 and elevated TSH? Well, that points to the tumor in the anterior pituitary. Normally, if the anterior pituitary is functioning, it will be sensitive to this negative feedback. In a tumorous pituitary, these cells are not responsive to the negative feedback. So they produce lots of TSH. Well, what does TSH do? TSH is a thyrotropic hormone. It increases the number of cells, increases the size of the follicle cells, and increases the release of T3 and T4. So a hyperthyroid cat might in fact have a tumor of the anterior pituitary, not of the thyroid. The thyroid gland may be responding normally because it's getting stimulus from the TSH. So this animal has an enlarged thyroid. There's a great vernacular term for that, goiter. So a goiter is an enlarged, a hypertrophic, hypoplastic thyroid. What if the tumor is in the hypothalamus? If the hypothalamic cells are no longer regulating TRH, they just produce excessive amounts of TRH. So we'll start here with our hypothalamus. We'll say that this is the tumor cell. All right, so it's doing its thing and it's producing large amounts of TRH. Well, it's going to stimulate the anterior pituitary to produce TSH. That goes to the thyroid, and that increases T3 and T4. So if the cat comes back with high T3, T4, high anterior pituitary TSH, and high TRH, that points to the tumor here. So who cares? The cat's got a tumor. Thyroid tumors, very easy to treat. Surgically, radiation therapy, I won't say mundane, but there are entire practices that kind of revolve around the treatment of this and do an excellent job at it. Tumors of the anterior pituitary, much more concern. Tumors of the hypothalamus, much more concern. And think about all of the different functions that are happening in the hypothalamus. We talked about oxytocin, ADH function. Well, if you've got tumor cells in there, even if those aren't the cells that are involved in the tumor, this tumor is growing and it's going to push the other cells out of the way. So you have this space-occupying lesion. It's in a very small portion of the brain. So in fact, hypothalamic tumors and anterior pituitary tumors, much greater concern. All right, so now let's take another scenario. You've got a cat. You're living in the Midwest. Cat gets a lot of corn. Not much else. Thyroid enlarged. You go, okay, is this cat hyperthyroid or hypothyroid? T3 and T4 are low. That, by definition, makes that cat hypothyroid. You then look at TSH, it's elevated. Releasing hormone, elevated. So the thyroid gland is responding to this stimulus by increasing in size. So this cat has an enlarged thyroid, it's goitrous. But in contrast to our tumorous cat, this cat is hypothyroid. It has low concentrations of T3, T4. Iodine deficiency. Inadequate iodine in the diet means you don't have the appropriate building blocks for T3 and T4. That's why the animal is hypothyroid. Simply doesn't have the material to make T3 and T4. Well, because T3 and T4 are low, the anterior pituitary says, values are low, I need to elevate them. How do I elevate them? I increase secretion. The TSH stimulates cell size, cell number, but you're still faced with a material problem. You don't have enough iodine, and while TSH also stimulates T3, T4 production, without a necessary building block, it's useless. So you end up with a goitrous animal, but in fact they're hypothyroid. Not a big problem in cats. It used to be much more of a problem in humans, particularly in the Midwest, because one of the richest sources for iodine are seafood. So you wouldn't see a lot of this goiter on the coastal regions where people were getting adequate amounts of iodine. But prior to appropriate shipping techniques and prior to the iodinization of salt. So next time you're looking at a salt shaker, look up and see if it's iodinated. See if it has iodine in it. And the rationale was everybody uses sodium chloride, an unbelievably important commodity. Think of all of the foodstuffs you use it in. If you were to put a little bit of iodine in there, then every time you use salt, you would get a little iodine. Used to be much more significant problem in humans, again, because of transport issues and feeding patterns, and also because in cats, you go out and you buy nutritionally balanced with adequate amounts of minerals and vitamins as well. It's really quite amazing. You've got these little packets of food that are balanced energy-wise, balanced for vitamins and nutrition. They've been doing that in the domestic animal world a lot longer than they have been doing it in the human world. And even to date, you kind of look at your diet, and it may not be as well. It's unlikely to be as well regulated as your pets or your domestic animals. So that's kind of our view of the clinical aspects of the thyroid gland. We're going to revisit this with some of our other tissues as well. Let's turn to plate 120, where we'll talk about the parathyroid glands. Embedded in the tissue of the thyroid gland are another set of glands called the parathyroid. They have nothing to do with T3 and T4 production, but they are embedded in the thyroid tissue. So here we are. Here's our thyroid, and there are discrete nodular tissue. So you can see these anatomically. This is the parathyroid gland. It has as its purpose the production of parathyroid hormone, parathormone, or PTH. Important in the regulation of calcium. So now we come back to how important calcium is, neurotransmission, the release of neurotransmitters, also is important in contractile function, bone production. What else? Well, we know calcium's important. Its regulation is under the control of two hormones, one being parathyroid hormone, or PTH, and the other one being calcitonin. The cells that produce parathyroid hormone are, in fact, from the parathyroid gland. They are the chief cells. The cells that produce calcitonin are, in fact, called C cells embedded in amongst the follicular cells of the thyroid. So speckled throughout the thyroid gland are these calcitonin-producing cells. So we talked about excitability of calcium, the importance of calcium. Reduced concentrations of calcium increase sensitivity of the cells, particularly neural cells, but at the same time tend to reduce the amount of neurotransmitter. And so you're kind of left in this situation of having difficulty in controlling skeletal muscle movements. And you can actually see elements of hypocalcemic tetany. So hypocalcemia just means reduced calcium in the blood. The hypocalcemia can produce this tetany, but it's very specific. And your book makes a reference to a spastic tetany in humans that you don't need to know about. You just kind of have an idea that low levels of calcium will produce uncoordinated contractions. In the domestic animals, we tend to see a hypocalcemia producing a weakness or paralysis. So paresis means weakness, paralysis. Too much calcium, a hypercalcemia, leads to ossification. That is the precipitation of calcium salts, calcium phosphate salts in particular, which are the building blocks of bone. So elevated levels of calcium, bad news as well. You start calcifying things like muscles and nerves, and you don't think nor act very well. We see that calcium is tightly regulated. pH, blood glucose, body temperatures. calcium is added to the list. And you don't have to know the concentrations, but recognize that it is a very tight window. Parathyroid hormone is released in response to decreases in calcium. So this little arrow here indicates a decrease in blood calcium, elevations in parathyroid hormone. It has as its target tissue then the intestines, where it stimulates calcium uptake from the gut. So we talked about calcium transport, that in fact requires PTH. It also acts at the kidney to increase reabsorption of calcium in the kidney. So you try to bring more in through the dietary source, you try to bring more back in from the kidney tubules. In contrast, calcitonin acts to decrease calcium levels. So the stimulus, and the way I remember that is it tones down calcium levels. So the stimulus for calcium, calcitonin, is too much calcium. It stimulates bone deposition. Calcitonin is very important in a growing animal. You've got the cartilage premodel. You need to deposit bone, calcium salts on the bone, and it is calcitonin that is very important in that. Bone deposition is under the control of the balance between two groups of cells, osteoblasts and osteoclasts. Osteoblasts are cells that tend to build bone. So these cells are stimulated by calcitonin. So lots of calcium floating around the blood. The osteoblasts take the calcium out of the blood and deposit it in the bone. The contrast to that is bone reabsorption. I need calcium. Where's the major store of that calcium? It's in the bones. So now what happens is calcitonin levels drop. That tends to favor osteoclasts. Osteoclasts are bone cells that chew up the bone, if you will, and make the calcium available for blood. So you have to understand the bones are kind of this deposition, reabsorption site. This is a storage place that you can store calcium, or you can give up calcium. The stimulus for that is in blood calcium. Vitamin D, third hormone involved in calcium regulation, is actually also considered a vitamin. Vitamin D3. Dietary intake of vitamins, and also sunlight conversion, requirement for UV conversion of active compounds, the involvement of the liver in taking this and producing in producing this hormone, if you will, from the vitamin. So here's the vitamin being taken in. You then start a process of producing calcidiol, which under PTH stimulus in the kidney produces calcitriol. So these are both hormones, and it is the calciotriol, which is the active hormone, which acts at the gut to increase calcium reabsorption. So we know that you drink your milk because of the calcium and also because of the vitamin D. Here is where we have one hormone, parathyroid hormone, working in concert with a vitamin D to convert it to a hormone that increases calcium in the blood. And the major mode of action is by increasing calcium transport in the gut. So having all three of these hormones, it's not like one is turned on and the others are turned off. They work in concert. So high levels of calcium in the blood, calcitonin goes up, parathyroid hormone goes down. When parathyroid hormone goes down, when this decreases, you lose your ability to reabsorb as much calcium. So you're working at the kidneys, you're working at the bone, and you're working at the gut then, all to regulate calcium. So what happens when it gets disrupted? Hyperparathyroidism. Like hyperthyroid, elevations in the hormone concentration. So elevations in parathyroid hormone. It's going to favor osteoclastic activity. Loss of bone density. Bones become weak and fragile. You know how important calcium is, right? It's in Tums, it's in gum, it's in cereal. I mean, we're kind of inundated with this concern of calcium deposition. And we recognize a condition of osteoporosis. This is, in fact, if you look it up, osteoporosis tends to be a compound of weak or fragile bones that is associated with adult females. So there's an estrogen component of it. A better term might be osteomalacia, or malformation of the bones. They're unable to form because of excessive parathyroid hormone. The bone, you've activated the osteoclasts, and so they end up chewing up the bone, making the calcium available for the blood. That, in fact, removes calcium from the bones. If this happens in a neonate, in a growing animal, you end up with osteoclasts going to town. The osteoblasts are downregulated, so you're not able to deposit bone. You're starting with a cartilage premodel. Cartilage, very thin, it's bendable, but you're not depositing calcium and phosphate on it. That is condition called rickets. So rickets in a young animal, as the animal continues to grow, the bone isn't getting stronger. So in fact, these individuals start bending, malformed bones, and the associated malformations with the rest of the tissue around it. So these animals grow up deformed. In an adult, it produces a osteoporosis or osteomalacia. Those individuals get pathological fractures. So the bone isn't strong enough. No longer have the cartilage premodel because they're adults. Bone isn't strong enough. They walk off the step and break their hip. Hypoparathyroidism. More bone deposition. So in fact, the bones become very enlarged, but there's an excessive amount of calcium phosphate. And the bones, instead of being very robust, become much more brittle. So you can see pathological fractures in both hyperthyroidism and hypothyroidism. We talk about the regulation of calcium. That's a really important ion in all of the things it's involved in. Recognize that the body, that's a positive, that's a cation. There's also an anion associated with that, and it's usually phosphate. So when we talk about calcium phosphate, that in fact is what tends to be regulated, and the concentration of calcium times the concentration of phosphate tends to be maintained relatively constant, and this is through secretion and reabsorption at the kidney tubules. The consequence means that if you have excessive dietary intake of phosphates, you in fact are kind of telling your body that you've got too much, and you end up down-regulating calcium. So elevated phosphate in the diet produces a elevation in PTH, right? The decreased calcium will stimulate, and so you'll now have a hyperparathyroid animal. Good clinical example are birds of prey. So you bring a bird of prey in, you're trying to get the animal to eat, you know that it's a carnivore, so you feed it hamburger, you feed it roast beef. High levels of phosphate in that diet. In fact, the diet is almost hugely high on the phosphate end. That high concentration of phosphate elevates blood phosphate levels. That will depress calcium levels. In response, parathyroid hormone goes up. This is what is referred to as secondary parathyroid hormonism. That is, this elevation of parathyroid hormone has nothing to do really with the cells, the chief cells that are producing the parathyroid hormone. They have to do with dietary levels. So, elevations in PTH, what's happening? Well, if this is a young bird of prey, they're essentially going to have rickets. They've got the cartilage premodel, elevated PTH, they can't deposit the calcium phosphate. So these birds grow up with malformed wings, malformed legs. If this is caught in time, there is some recovery mechanism. What usually ends up happening is these birds really like the meat. They eat it voraciously. They tend to be growing fine, except now they start getting, they're not flying, they're having trouble walking. And by the time you get to that point, the bones, the animal's too large for its cartilage bones. You recognize the problem. You then start feeding the animal adequate amounts of calcium. The calcium then deposits on these malformed bones, and you have now a bony malformation that will seldom recover. So this is a not uncommon problem in feeding some of these animals. So you really need to be concerned about not only feeding adults but feeding growing animals. If you look, any student of raptor behavior, one of the first things that raptors eat is not the meat, is they tend to go in and eat the digestive tract. So they're getting a fair amount of calcium from the GI tract. So while we think of them as these real meat eaters eating the flesh, they are eating the animal, but they're eating the whole animal. One of the common food products up at Davis that they fed the raptors were baby chicks. Well, think about baby chicks. Baby chicks, young, they don't have well-developed bones. So, in fact, they don't have a lot of calcium deposits. So our treatment for the little chicks, they were dead, we'd dust them in a bone meal, in a calcium-containing meal, and then feed the animals that way. So they were getting adequate amounts of calcium as well as other nutrients. All right, so we've talked about secondary parathyroid hormonism. What else do I need to talk about? Milk fever. We have bred dairy cattle to produce large amounts of milk, 20,000 pounds of milk a year. Milk is characterized by having high concentrations of calcium. Well, where does that calcium come from? It comes from the blood. So as the blood flows through the mammary glands, calcium is actively removed from the blood, brought into the milk, and under the influence of prolactin, the calcium is converted into a milk product. In an animal that has a high production record, that means there's lots of blood flowing through the mammary glands, through the udder, and there's lots of calcium being removed. Milk is produced in the highest concentrations immediately at parturition. So the animal starts milk production a couple days beforehand. The udder starts to swell, but as soon as that calf hits the ground, you now have this tremendous stimulus for production of milk. Now, you've bred these animals to produce large amounts of milk. These animals can be faced then with a hypocalcemia. So parturition, or birth, increases milk production. Lots of calcium in the milk. That decreases calcium in the blood. These animals become hypocalcemic. We give the example of a hypocalcemic tetany in humans. In dairy cattle, it presents not as a spastic tetany, but more as a paresis or weakness. They don't have enough calcium for muscle contraction. They don't have enough calcium for neurotransmission. They're weak and they fall over. The old term for this is milk fever. It has nothing to do with fever. They're afebrile. If they happen to fall over in a field, in Bakersfield in the summer, they're unable to move, so in fact their body temperature will elevate, but again, it's an afebrile condition. It has nothing to do with an infection, and it's a misnomer. It is more correctly post-parturient paresis. Why? They're weak because low calcium right at freshening, or right at high milk production. So how do we deal with these animals? Clinically, you treat them with calcium IV. You've got to regulate calcium within a fairly tight zone, so you can't just add as much calcium as you want. You need to tighter in, you need to deliver it, you need to listen to the heart rate, because you can kill them with too much calcium. But it's one of those miraculous kind of recoveries where they will go from an animal that's recumbent, laying down, to standing up and running off in the field once you've adjusted those calcium levels. Well-managed dairies will in fact deal with this by altering nutrient uptake. In California, we feed tremendous amounts of alfalfa. Get several cuttings in our fields, very rich in calcium. So high in calcium. What does that do? High dietary intake of calcium. What is that going to do to PTH and calcitonin? High intake, increase, decrease. That is going to favor bone deposition. Those are going to favor decreases in calcium in the blood. So by giving these animals large amounts of alfalfa right before they undergo parturition, you are setting yourself up hormonally for post-parturient paresis. Consequently, management decisions will be to reduce the amount of calcium about 2 weeks prior to parturition. So there you go. Hormones, good to know. I think we'll stop there.